Hi, this is Ellie Fields, licensed professional counselor with the Attachment and Trauma Center of Nebraska, and we are doing a presentation today using a fabulous presentation packet put together by Emdr, and we're having a conversation and discussion about using EMDR with individuals who have dissociative identity disorder or very complex dissociative experiences, all due to trauma. And we're just trying to get a better understanding as clients with dissociation, individuals with dissociation can think about using EMDR in their private therapy or looking for therapy and what they might come to expect and precautions and so forth. So we're going to go through these slides. We have a place in our presentation to ask questions. Individuals are going to type questions, and I will answer them before I move on to each slide. And we definitely invite everyone to put out there any question you have, because remember that if you have a question about it, somebody else might be wondering that as well. So there are no bad questions. Everyone will benefit. So we just watched a deep little video on watching somebody receive EMDR treatment, and I was just making some comments about how we have very adaptive protocols for people with dissociation and DID, and just like EMDR is an adaptive information processing model, it is a therapy that we use with people, but it is also a treatment approach. It used to be referred to as just a technique, and now it's an entire way of conceptualizing a person and their life experience. And I think that says a lot, particularly about people with DID, because DID is a very adaptive response to a maladaptive environment. So, EMDR stands for eye movement desensitization and reprocessing, and that name alone really doesn't describe what EMDR is, because now we use tactile stimulating devices or tapping on somebody's hands like we saw in the video, and we also use auditory tones. So it's not just about eye movement, but the eye movement speaks to Francine Shapiro's original discovery using eye movements. So it will probably always be thought of that way, and that's wonderful. It is now being used around the world, and it is one of the more, if not the definitive treatment for post-traumatic stress disorder. And the World Health Organization has made the recommendation that if a person is suffering from straightforward PTSD, cognitive behavioral therapy, and then EMDR is recommended before medication is tried, that being the third line of treatment. So it's really come to the forefront of treatment around the world. In fact, the United States is one of the only countries that uses it the least, or is still reluctant to use it readily. So here again, we're just looking at a slide that just says that it is an evidence-based psychotherapy. It is the most researched form of treatment out there now, because it's just been very important to validate the efficacy of how helpful and important this is. The model about EMDR, adaptive information processing, basically looks at just how the things that we adapted to in our early life to cope with dysfunction in our family was adaptive. But as adults, as we've moved on and we are no longer in the disturbing environment, we need help changing that process, because now it is maladaptive. And EMDR is really very, very helpful at helping make that shift and taking some of those coping skills that put barriers between us and the threats or the disturbing events, and shift them to make them more adaptive and helpful for today's world and for today's adult experience. And it says here, the maladaptive experience impairs our ability to integrate experiences in an adaptive manner. And that's really a defining piece of being DID. the impairment, as they are calling it, are all the walls that go up so that the information is not shared. It is totally and completely separate. EMDR, the goal of EMDR is not to bring those walls down. So I want to make sure that everyone knows that that is not the job of EMDR with DID. This is a nice, just little picture of the brain, pointing out the different parts of the brain and why these pieces are important. The neocortex, or thinking brain, is what we think of as our rational thinking part. The limbic is our fight and flight, emotional core. The brainstem is where that physical body gets activated when we're experiencing issues around safety. Trauma in the brain here, it's stored in all parts of it. And what we want to remember is that trauma from our childhood, when we've got DID, it is so completely and totally stored separately. We've got, parts or alters of our system that are serving as containers that have really sealed that off. And the potency and high concentration of material that parts of our system store, it's really overwhelming to think about how to let that out without feeling devastated or annihilated, because the concentration levels feel so high of memory, of traumatic memory. And the adaptive protocols that we use with EMDR now are about thinking more as far as titrating, like if we were to just extract only the tiniest, smallest parts at a time and working with that a little by little by little, desensitizing, not doing something all at once. And unfortunately or fortunately, it was through early experiences with EMDR that we realized how powerful it was if somebody had dissociation. You didn't have to even be DID or DDNOS. If there was dissociative material and you did EMDR and your therapist did not screen for dissociative experiences, an EMDR session could literally punch a wall in the hole of a dissociative barrier, and the client would be flooded with very, very intense, overwhelming memory that they didn't even know they had. Nobody wants that to ever happen again, which is why therapists are routinely urged in all levels of training, do not do this unless you have screened for dissociation. That's not foolproof because, of course, not every dissociative client realizes they're dissociative. So, we do the best that we can to not have those experiences ever happen again. And we don't do EMDR once we know someone is dissociative. We don't do it until much, much later in the therapy. And again, it's very tailored and specialized now for DID. This is just another slide talking about the three-pronged approach. It's an 8-phase process of treatment. We address the past, the present, and the future. The bilateral stimulation, BLS, we do eye movement, tones, or taps. We might use all three together or any combination of those or just one. So we just really try to work with what each person wants. And even though you see here psychodynamic, cognitive, behavioral, client-centered, mindfulness, it can be integrated into most theories or philosophies of psychotherapy. Not all, but most of them. And this is just a nod to Dr. Francine Shapiro, who has been the discoverer of the power of EMDR through her own experience. And we're very, very fortunate and pleased that she went on to develop this protocol and has just had an amazing level of integrity when it comes to treating and training other therapists and the therapists that she's taught to train other therapists. It's a very professional, high level of thought going into it. Again, this is just sort of speaking to some of the foundations and principles of the protocol, and it's going to go into more detail as we go forward here, so I'm not going to spend a lot of time on this. This is just taking a glance at different areas of psychotherapy that maybe people can do their own research on afterwards if they want to find out more about what's the difference between psychodynamic, cognitive behavioral, and then we see EMDR, all of them as their own discrete therapies. But these are pretty straightforward explanations. And like I said before, EMDR therapy can integrate all of these. It really just depends on your therapist. So this is a really nice slide to look at, this idea of unprocessed memory, stored memory, and it encourages us to think about memory in different ways as unprocessed. And what does that mean to us, that something is unprocessed? Does it mean it's unrealized? For most of my clients, they kind of know that it's there, but they've never really been able to look at it in its entirety. And a lot of that is because, as you see in this slide, it's divided, it's broken up, it's fractionated into pieces. The body sensations, the emotions, the thoughts. Triggers are what sort of poke at us from the outside or inside. You know, if we have a triggering thought or somebody says a triggering phrase, or we're on an anniversary date and we're just kind of feeling open and vulnerable, any of those pieces of memory might get activated just because. And then, of course, looking at the images, sounds, smells, tastes, and feelings. And then on the left, part of the memory is that we've tried to deal with, or a part of us has tried to deal with, is what does this mean that this happened to me? And everybody who experiences trauma has some what we call negative beliefs about their self, or negative cognitions. That's what NC is, negative cognition. The gentleman in a video we watched had broken up with someone, and I think his negative cognition might have been something like, I'm not strong, or I'm not lovable. They didn't have the full recording available with that, but we can have many, many negative beliefs about ourselves that when we experience those in current time, again, it hooks into those older pieces that are also attached to trauma memory. So there are a lot of different pathways to activate trauma memory. And again, some of it is processed, some of it is not. Some of it may be experienced as new, and some of it might be just familiar. So when a traumatic or disturbing event happens, our natural system for processing memory is interrupted because of the chemical arousal in our body, our fight and flight system kicking in, because the goal is to survive, not to process the event. The information at the time of the event is so upsetting and overwhelming, it gets stuck. When we're DID, the event isn't just upsetting, it is catastrophic to such an extent that there is no coping skill for this any other than to go away. And so that is the extent to which this piece applies to DID and dissociation. Present-day triggers or experiences can activate the feelings, responses, and so forth stored in memory. And all of these do apply to DID. Persistent and intrusive thoughts, we may have parts that obsess over things. We may have parts that are more negative than others. We may have parts of self that are more critical and negative of ourself, of maybe the front part of the self, that there's just a lot of criticism that comes forward about how people are handling things. And then we might get a lot of poking, jabbing, very intense physical sensations, headaches, tightness, and one might begin to understand that my alters or parts of self are a part of that as well. I'm not saying it explains everything, but it certainly does contribute. The adaptive information processing model distinguishes EMDR from other therapy by looking at the present situation producing distress simply as a trigger for a past unprocessed incident. So lots of times what this means in my office is when a client comes in and says, I don't understand why this is upsetting me so much. I know I can handle this, but for some reason I I'm falling to pieces every time I sit across from this person at the table, I'm probably going to encourage them to look at, well, who does this person remind you of? I'm wondering what it is about them that feels familiar, that is possibly connected to someone who has hurt you before. I can say that to somebody with DID. I can say that to somebody without DID. So that is not a DID-specific thought or process, but it's a way of beginning to think about how and why we get so activated sometimes in the present. Or if you don't know why this person is familiar, asking inside, does anybody inside know what it is about that person we ate lunch with yesterday that left us feeling so unsettled? Is there any part of the self that can speak to, was that individual familiar or remind us of someone that wasn't good to us? So that's just good investigative work on your part. Here we have just a comment about natural information processing. Folks who are healthy and have more secure sense of self, new experiences are taken in, sorted through in terms of what is useful and is learned. And then it gets linked to our feelings, and it's accessible to the person to use in the future. Like remembering that when I sit next to this person in class, I seem to have a better classroom experience because they don't bother me or distract me, and I'm going to try to sit next to that person in the future. And that's where the learning takes place. It could also be a negative experience that teaches a person not to be near another person in the future. For individuals who are not as healthy, new experiences are taken in and sorted through at a more elevated limbic, again, that fight and flight state or emotional response, and those experiences don't allow for adequate processing to complete an adaptive resolution, meaning it interrupts the learning. Because we dissociate every time that gets activated, the connection to the person or the learning event is disrupted. It's not really all or nothing, but that is a big challenge for people who dissociate. Trauma has been described as the disruption of inherent processing that leads to normal or to healthy integration and adaptive resolution following upsetting experiences. Bessel, Vandercook, and Fissler, that's their quote. They are leaders in our field and really know what they're talking about there. Under normal circumstances, information processing can occur when we think, talk, doing artistic or expressive activities, or dreaming. In trauma, however, malfunction is the natural information processing system which occurs, such as the experience of the trauma is frozen, manifesting in persistent intrusive thoughts, negative emotions, self-reference beliefs, and unpleasant body sensations. So because, again, a part may come out and basically on the entirety of the experience, it does not get processed, but it just gets held back and does not get processed. And these are the different pieces that parts can hold back, or multiple parts can take on, depending on the degree of intensity and how bad it was. We may have a part that needs to come out and just take the pain. The body is so bad. And you know, this is just a very, DID is a more sophisticated, involved adaptation to taking on more intense, maladaptive experiences. So it is just literally taking everything that we're saying here to another level to cope with and adapt to an overwhelming environment. I'm going to skip over this example. It's an example of something very straightforward. I think it's hard for me to apply this to DID at this point. Describing EMDR to a client, even though some of you got to see the video, this just is a straightforward. The disturbing event occurs. It gets locked and frozen in the brain. In EMDR, we're looking at what does it look like? Were there sounds, thoughts, feelings, and body sensations? What are the present-day experiences activating them in the form of either feelings, thoughts, or images or sensations in the body? EMDR seems to stimulate the frozen information and allows the brain to process it. It brings it forward to the part of the brain that actually wasn't able to process it at the time. It got stored in the limbic area. So by doing the bilateral stimulation, EMDR brings that to another part of the brain where it can finally be looked at differently, understood differently, incorporated in a part of our brain, the prefrontal cortex, where we can actually, if the mouth's job is to chew, we call it mastication, break down whatever we put in our mouth. The prefrontal cortex really is that piece of our brain. It allows us to chew on that memory, break it down, and understand it in ways we've never been able to just because of the nature of how that got stored. And sometimes in dreams, we have the fortune of being able to do that. And so part of EMDR is about recreating some of that rapid eye movement back and forth. And this picture helps us see that too. Dual attention. I'm in the present, but I'm working on a memory from the past. Parts of my body are going to get activated, but then a part of me is going to stay grounded into the present. And we really work hard on keeping our clients present for any processing because it can get overwhelming. And with DID, again, like I said, we really slow it down. We break it down. We just might work on one tiny sliver of a memory at a time. We might just focus on, break it up as far as moments of time. We might break it up as far as let's just do the pain during one session, or we might just focus what the right arm experienced. Next week we'll do the left arm. Again, I will work with each client to whatever level of consideration or specificity is needed. These can be very overwhelming and difficult sessions, and a person needs recovery time afterwards. And taking it slow is really the theme for anybody with DID, as hard as that can be for parts of self to hear. There's always the part of us that wants to get it done yesterday and be done with it. Of course, that's just so bad for us that your therapist should never agree to that. This is just some more comments about describing this to someone. It does not take memory away. You will still remember it, but it may change in that it will feel distant, vague, or just not as distressing. It will not take away information that is not true or that you need to hold on to for your well-being. You won't forget the good things, or the meaningful things, or the important things. It is your own brain doing the healing. You're the one in control during the session. And it says no placebo effect. Many therapists will do EMDR. They haven't done the screening for dissociation. And I get a lot of these referrals where the therapist will call and say, well, EMDR just doesn't work for this person. They just kind of, they're just like staring off and going away. And I ask them, well, did you screen for dissociation? And, almost always they've said no. And dissociating in response to doing EMDR is, again, I would say, a very adaptive response because it is highly distressing if you are not prepared or the dissociative aspect of an individual has not been taken into consideration. So if you've tried EMDR and you are dissociative and you did not have a highly specialized EMDR approach or an adaptive approach, or you did this a long time ago before we had procedures, chances are you did exactly what you were supposed to do. You didn't fail EMDR. EMDR failed you in that your therapist failed to take care of you in that particular moment. Your therapist probably failed to consider that this was going on or just didn't know, but should have taken the time to know if they had had the training. I can only, assume so much. I do believe all therapists mean well. So I'm not trying to talk down or speak poorly of other people's therapists. It's just that this is a pervasive issue. Again, EMDR is used to access dysfunctionally stored information. It's used to stimulate the information processing system and maintain it in a dynamic form, which just means we're trying to continually move this information from on ice and cold storage and bring it forward to thaw and be worked out, massaged, understood better. The information, by monitoring the free association process, meaning we're just asking, what are you getting now? What are you noticing? And we are encouraging just noticing. So just a very mindfulness-based approach in relationship to what is happening. When you've got DID, that's very, very hard. It's very hard to just notice without being completely sucked in and pulled in. So you and your therapist will have to do lots of preparation for grounding and centering before ever doing EMDR. You'll just need a lot of preparation for that, and that's just important. Desensitizing is when we're taking this memory 0 to 10, 10 being the highest level of distress, 0, none at all. Regardless of where they start, at the end of the session, we'd like to see that down to a 0. Sometimes it's a 1, simply because it was so awful. It really seems impossible that it could ever be a 1. That just wouldn't make sense. And of course, we make room for that. Reprocessing is about, now that that level of distress is so low, there's room to consider a shift or movement in the negative thoughts and feelings we've had about ourselves, such as, I'm not in control, might shift into the realm of, I am in control now, or I am learning to be in control now. And through more bilateral stimulation, only again working with what is right and true in each individual, reinforcing any positive shifts that are taking place in that direction. When they think of the memory, how strong does that thought feel to you right now, is the sort of phrase we will use. And based on how they report that, we will explore how that is getting stronger and stronger, and certainly encourage them to consider how that feels when that is getting stronger and clearer in their mind and in their body. During EMDR processing, we're talking here about inside, they are coming up with corrective information about the event rather than the information being externally generated through discussion with a therapist. So we're just simply saying here it's different. We're not trying to convince a client to think of it differently or to feel differently about it. We're really sitting back during EMDR processing and allowing that information to come from inside the person naturally and inherently. And that just feels so nice as a therapist to know that there is information inside this person that can support them, that makes sense to them. There are times that we do need to provide support. If there isn't the corrective information coming forward, we try to explore what may be possible, what might be different, and try to open doors for them in that direction. We do whatever we can, though, to not insert or put in information that is not already there. We're not in the business of creating new memory, ever, ever, ever. Here it says the therapist does not reflect, interpret, reframe, or intervene in other traditional ways. So we're following the client. The client is leading. We're using the mindfulness approach. Go with that. Just notice. Cognitive interweaves, like I said, we might ask a question like, really possible that you can never be in control? Challenging some of the negative beliefs that might be coming up. But we only do that when the person needs just a little boost to to get sort of space. I'm trying to think of a negative belief sometimes that can get really stuck, such as the belief that I am in danger. Many of you have that negative belief, particularly if you think about a past event. Hopefully, many of you are in situations now as you look at your life where danger really is not an immediate situation. And for all intents and purposes, you might be able to say on a good day that most things in your life are going pretty well, or that you don't have dangerous people in your life. We always have to frame things in a realistic, truth-centered way. We can't make anybody think or feel something that they aren't ready to, that isn't true inside them. So just trying to pull folks into the awareness that it might be possible that someday you could believe that you are worthy, or that you are deserving of some happiness, or that you now can have choices, or that you can learn how to have choices. These are examples of positive cognitions, beliefs that might feel really out of reach. And EMDR works with those in terms of integrating the negative thoughts that we have from our history. This is just looking at the 8-phase protocol. These are the steps one follows, which are pretty straightforward and fairly obvious in many experiences for any therapist, that we understand a client's history and we form a treatment plan or a direction that we're going to take with them. We prepare the client. In EMDR, we do things like talk about developing a container and a safe place. We maybe some imaginal or real support people inside. We assess their readiness. We assess what they need to do, what memories they want to work on, what their negative beliefs are, and the experiences that they're having. The desensitizing is the process where we're doing bilateral stimulation, working on the memory. Hopefully the level of distress is going down, down, down as the session progresses. Installation is the part where we are looking at the positive belief. The body scan is looking at what the body is experiencing. I work a lot with the body throughout the session. Our bodies can't lie. And so if my client tells me I'm fine, but I see their jaw tightening and their legs are pressed together, I'll be sure to include that when I say, well, I'm glad to hear you're fine. Could you tell me how your body is feeling? And then they get to check in. So when we've got DID or any kind of dissociative experience, that's kind of an example. We just are actually not feeling a lot of things that are going on, and we may have disconnected from what the body is experiencing. So the body scan is actually very important when we're doing dissociative work. Sometimes we might only do the body. Closure is really just about bringing the session to an end and then reevaluating that session and the following sessions. How's it going now? What does that memory look like now? We're going to look at core memories, themes in our life, the earliest ones that laid down the foundation for the presenting problems. When we've got DID, we might, just for the record, want to know where some of those first splits took place. And, creating a timeline of when other splitting took place. Identifying clusters and themes. Again, were there events that occurred just around certain individuals or at certain phases or times in our life? Things get broken up in such a way that it's sort of, when we've got DID, we sort of know which parts of self represent different times, or we develop an idea of that anyway, depending on where everyone is with their process and working with their diagnosis. It's everyone's in a different place Processing an event, we're going to look at what currently is triggering, what are the stressors. Of course, stressors are going to be things like, how are things going in my body, in my mind? Am I getting sleep? Am I taking care of my body nutritionally? What's going on in my relationships, family, friends, partners? These can be good stressors, and they can be unpleasant stressors. A stressor can also be, as well as a trigger, anniversary dates, times of year, holidays, and a recent event that just pops up. Processing future events, that's something that can be done on its own or following an EMDR session where we look at the future. If we've processed something really difficult around, let's say, an individual from our past, but we know we're going to see them again in our future, doing some EMDR around, well, can we imagine how you would like to think and feel, or how you would want to see yourself behave if you were to walk into an event and see this person in the future? And we do what we would call more of an installation, resource installation, or that's one protocol or future template where we're really desensitizing or processing a future related experience. And we check those negative beliefs in that process as well. The recent event protocol is for something that's happened in the last 3 months. That's a very specific event. Again, probably not going to be used with DID. I'm going to pause for a moment and just kind of check in. I know I've been going pretty fast. There's a lot of slides, so I'm trying to move through this. But I want to give somebody time to type questions, remind you to type questions, if there are any, because I do want to be able to address that. So what you see here, 90 minutes for a processing session. Unless a person is self-pay or, I don't know, every therapist is different. Getting 90 minutes in is kind of tough. Sometimes if my client is, well, I'm going to stop talking about that. When you've got DID, 90 minutes is really, really important. So most of my clients that I'm doing, my non-DID clients, I use 45 to 50 minutes. DID, I would absolutely need 90 minutes. I might even use more. So you really need that cushioning of time. It just is what it is, and I don't know that I love that expression, but it's just really important to have time to do this and not for the therapist to feel rushed or for you to feel rushed, because sometimes we just don't know how things are going to go, and we want to have time to handle that. The targeted memory is going to be something that probably will be chosen prior to the EMDR session. There will be so much known going into a session when you've got DID as far as what we're going to work on, what parts of self will be present, who needs to be tucked in, who needs to be in safe places. All of those things will need to be in consideration for EMDR when you've got DID. Can I have a comforting, nurturing, protective part that is supportive of doing a trauma processing session? If we have any parts of self that are opposed or not on board, that has to be acknowledged and processed. Not processed, but acknowledged. That should be worked through with the system, if not definitely the therapist. The therapist should never proceed if there is anyone absolutely objecting. They will undermine the session, and you know what? It's their right. Everyone has to get on board. And one option can be, after hearing out the concerns, worries, or fears of the one objecting, invite them to stay nearby if that's something that they want, just to keep an eye on things. But there should be no forward movement with EMDR processing without the consent and support of every part of the self. So that's, respect trumps everything. And it would be so disrespectful to go forward in any trauma processing when we've got DID. It would be so disrespectful to move ahead if there is a part of the self that objects or is saying, please stop, don't do this. And maybe they're not saying it that nicely, but you know what I mean. They need to be heard out, and the therapist needs to hear what the concerns are. Number of processing sessions. I'm not even going to say this applies to DID in terms of you just can't set a timeline there. So this is for the straightforward client that is not dissociative. This is a childhood trauma example. Again, I'm just going to sort of let you look at this. It's not a good example for this group, but it can give you some idea. This is an older woman sexually abused by her alcoholic father when she was a child. These are her presenting problems. Her negative belief or thoughts about herself was that it's my fault, I'm bad, I'm always vulnerable and in danger, I have no control, and we could probably add about 10 others. The positive thoughts and beliefs, again, at the beginning, we understand that she doesn't really think or feel these things, but she would like to someday. That I did the best that I could, that I'm a good person, that she can feel like it's over, that she's safe now, that she has choices and a reasonable degree of control. That's a highly personalized statement. I have choices and a reasonable degree of control. This is not a cookie cutter type deal. This has to be very personal. So we expect that somebody just getting started is not going to have these positive cognitions. While they sound nice, they think, well, that's what other people have. I don't have this. But literally the EMDR will get you closer to those feelings, and that those are feelings that actually belong to you and feel real inside you. Again, it has to be your truth, not truth defined by the therapist. These are, again, examples. We'll start at the left at the image. My father's at the bedroom door telling me to take off my clothes. This feels a little like it might be triggering. But just kind of at a glance, don't read the small print. She's identifying a traumatic memory she would want to work on. She's got fear, sadness, and anxiety, her negative beliefs that you've already heard me say. She's got physical sensations in her neck, shoulder, knots in her tummy and in her chest, and the triggers that are going on in her current life. This is an example as the assessment is going. This will be right before the processing. The negative belief is I'm in danger. We ask the person to pick the negative belief that's the strongest, and the opposite of I'm in danger is I'm safe now. How true that feels to her is a 2 out of 7. 7 is it feels completely true. 2 would be not very true. 1 would be not at all. The feelings and emotions she's feeling are fear, sadness, and anxiety, and SUD, S-U-D, stands for Subjective Units of Distress. That's the 0 to 10 rating we check in the beginning and throughout the session. So she's at an 8 out of 10. And these are the places in her body she's feeling it. And this is about, once we've got all that information, we're going to say, okay, let's go back to the memory and those words, I'm in danger, and notice where you feel it in your body, and we're off. We're doing the bilateral stimulation. And her only job is to just notice whatever comes up. There are no supposed to's. She does not have to, we don't want her to hook into anything as whether it should or shouldn't be there, but just to notice what pieces of the memory are going in front of her now. As a result of her doing the processing, she recognizes she was innocent and betrayed by the person who was supposed to love and protect her. She has grief feelings over the loss of her innocence, and she's able to express the anger towards her father for the first time, probably in session with her therapist, not to the parent. She's experiencing a greater sense of compassion for herself and an increased sense of self-respect as a survivor. With regards to safety, she recognizes that the abuse is truly over and her father can no longer hurt her. So everyone here knows that you can do this kind of work whether the person is dead or alive, the person who hurt you, whether they're involved in the therapy or not. All of this is available. These are possible information processing shifts. She can begin to acknowledge the choices she's made in her adult life to basically have a different life, having boundaries, trying to connect with supportive people, making a commitment in therapy. Hopefully these are things that all of you recognize you need to do. Particularly when life starts out really bad, it's harder, but you're all fighting with DID. You're fighting to learn what it is to have boundaries. You're learning, hopefully, how to feel safer or more connected with people and toying with the idea of having relationships. Felicity's website and the different groups is a really, really important and great step towards learning how to have connections safely with lots of boundaries, security. It's a great first step. In the case of the child, the woman, she gets to consider new possibilities for the future because the load of the trauma is now not clouding her every thought and daily experience. And she's able to express and connect with newer friendships, activities, and has some hope she didn't have for before. I'm going to skip over the next example and pause again. I still don't see any questions coming up. So let's all just take a deep breath. And maybe I need to scroll down. Whoops. Okay. Sorry about that. All right, I see. Can you please put the slide up again that shows the 8 phases? You bet. I'll do that. I am so sorry that I didn't scroll down. I thought they were going to pop right up. Okay. The 8-phase protocol. There's that. Visually, I apologize for not seeing that before. So there's that slide. And then I see, as a child, I used to dream about abuse. How come dreaming itself didn't clear things out like Emdr does? That's a good question. I think, and I'm not the expert on dreams and sleep, but we can only get through so many pieces at a time. And it's sort of our unconscious mind working on it. But I guess full processing means that unconscious comes to the conscious in a more complete way when we are conscious. So while the dream is working on pieces of this, I don't know until it's been fully realized in a waking state if it can be done. But I'm sure that there are folks out there that have done a lot of writing and research in this area. Let's see. I had a couple of T's use EMDR in the mid-90s, and I think I just went away. But once I freaked out badly, is it too late to do EMDR? It's never too late. Absolutely never too late to do EMDR, and I'm sorry that you did have those experiences. I wouldn't want anyone to give up on it. You just need to find a therapist, like I said, that has done some of the added training and really has exposed themselves to consultation with EMDR therapists that have developed an expertise in this, like Sandra Paulson, who will be speaking at the conference in Seattle. I did consultation with Sandra along with a handful of other therapists here in Omaha. Once a month, we reviewed cases with her. She's written books on using EMDR with dissociation, and she's just outstanding, talented, and I can't say enough nice things about Sandra. I wouldn't be the therapist I am today without her. So, but we need consultation. We need 2, 3, 4 heads are better than one when it comes to treating DID. We have to be creative because you are creative. We have to be as connected as you will allow us to be to you, knowing that that's not going to be very much. We need support as therapists to work with DID because of the complications and the challenges. And, you know, we want to maintain hope as we move forward, and we want to maintain our level of expertise. We don't want to get lost in this with you. It's really, really important that your therapist is taking care of themselves. Well, that's not your job to monitor that. You do want them to be hopefully consulting, if not part of a peer group of therapists that are discussing cases. Very, very important. So you can ask your therapist that, and I would encourage it. And I would ask them if they've had training in using EMDR techniques with dissociative clients. So there is specific training for EMDR and therapists. It's Emdr.com is the institute. I'll write it down here. There's two. And Mdr, the group that created this presentation, they do all the more advanced education. Whoopsie, I connected those. My apologies. It should be emdr.com and then emdr.org. They're two separate websites. EMDR is the institute, the facility that does the official first two levels of training, and then Mdr is doing all the advanced training after the first levels of training have been completed. So those two are the resources. A lot of therapists that don't go forward with EMDR training don't because it is expensive. That's a relative term. I just think personally, if you're going to be doing intense trauma work and working with very, very complicated clients with complicated trauma history, this is a tool that will empower you as a therapist and certainly empower your clients, because I have answers and support in the therapy and the training that I've done that supports me with my clients. And that it's just very exciting to know I have something that I can give you that I know will work. And it doesn't cure or take care of everything, but it helps a ton. So, you know, that's just saying this here. EMDR is not a cure or a magic bullet, but these are just a list of results that and topics that people can be using it with. EMDR can be used with weight issues. Absolutely. There are some special protocols for weight loss. I think and this is just not knowing anyone in particular, but I think about my own DID clients with weight issues. Pardon me, we're really looking at, I wonder, you know, first of all, what's been adaptive about my weight? How has it protected me? How has it provided a shield for me? And when I start to lose weight, what parts inside are most activated or become anxious or begin to feel unsafe? Those things absolutely have to be addressed before we do EMDR on that. And so if I think about alters or parts that do more of the eating or drive more of the dissociative eating or eating at night, they need to be able to come forward, and we need to get to know those parts of self that are doing that. We need to give them alternative strategies for calming and soothing. So I think that's very important. I wouldn't go into a weight loss EMDR protocol without first having addressed the parts of self that are, you know, kind of most involved in that challenge, if that makes sense. I hope, Jolie, that is speaking to what you're asking about. The Mdr website will probably have the most exhaustive list of different protocols or procedures available with EMDR. Can DID be reestablished after integration by EMDR? There's a fear that working on these other issues will bring them back. It's a perfectly good question, and I'm going to think about that. And I feel like I'm going to give you the best answer I can right now, but this answer should be saved and looked at with Sandra Paulson. And I would hope that somebody, maybe this is something for Felicity to think about, questions being written down today, and if Sandra is open to questions at the conference, that we can give her some questions to answer at the end, if she can save time at the end of her lectures on Saturday and Sunday. That these have been some questions that have come up that she might be willing to speak to. She would be a wonderful person to answer these questions thoughtfully and thoroughly. I understand that fear, and because I can't tell you, I have not done EMDR with someone after integration, so I can't even speak to that based on experience. That's not necessarily by choice. I just haven't had the opportunity. I think that I'd like to say that it's possible, and I guess, again, I would be looking to a highly skilled individual. I see that you're in Georgia. There is a woman named Kathy Steele in Atlanta who is a leader in the field of using EMDR and DID. She's with ISSTD. I saw her speak 3 different times in Baltimore this fall. She is the number one person that I would turn to in your neck of the woods. She's in Atlanta. If you just Google Kathy Steele, I'll write her name here. I don't know how, Kathy is also an EMDR practitioner. But she also, her biggest piece of work has been with dissociation. So, she's right there. If you're close enough, she's definitely worth looking into. And she would be able to answer that question, or even, like I said, devise a more personalized plan for, well, if that is a fear, worry, or concern, let's think about what we can do to maybe put in barriers if we're worried about that, of any splitting taking place, where those vulnerabilities are. I think she would be able to work with that. So these are just sort of some organizations that provide support, information. I put down the 2 websites you see here about Emdr and Emdr.com. Why and how does it work? This is a question that is routinely addressed at our national conferences and international conferences. Is it the eye movements? Is it that we relax when this is going on? Some part of the body works. They're still trying to uncover what exactly is happening that makes it work. And so these are hypotheses. These are guesses about why it works. Something about our neurophysiology. Is it the REM sleep? The orienting response, what they're talking about is sort of that turning to and towards the difficult piece and the focused attention we're giving on it. Working memory, parasympathetic response, those are the fight and flight versus the calming and relaxing. And they're wondering if it's the calming and relaxing part that is part of what begins to change how this information is stored in our bodies and in our minds. Another one, again, they're just sort of elaborating that REM sleep reconsolidates the information. It sort of brings it up, jumbles it, and it feels like something's been worked on there. We don't really know. Orienting, the bilateral stimulation, like I said, focuses the attention on the traumatic material. And we're wondering if it disrupts the associations in our networks. Kind of complicated to think about some of these ideas. We saw this gentleman speak this year, Robert Stickgold. He's just fascinating, his studies on sleep. Some suggest EMDR helps in the treatment of PTSD by turning on memory processing systems normally activated during REM sleep, but dysfunctionally in a PTSD patient. So, the whole matter of sleep, he's a sleep researcher, so he is interested in, is this REM or not? And then he's also looking at the different memory systems in the brain. When we're sleeping, we're moving stuff back and forth from experience to meaning. How does this make sense in my world? And then it goes back and it gets more about what happened today. That's the episode memory. And then it comes back to the other neocortex and figures out, well, where does this fit in my life? What does this remind me of? What does this mean to me? He talks about recovery from trauma depends on processing trauma in their episodic form. That means what happened now, into the general semantic meaning, what does it mean to me? How this all applies to DID, I don't know that I can really even say, other than this still holds true. This is just sort of looking at the smallest kernel of what's underneath it all. This would be true for anybody doing EMDR on anything. So these are just, again, educated guesses. He's very involved in the research, though, and has a big team of researchers at his side helping him to try to figure this out. He wonders if EMDR, through repetitive redirecting of attention, activates the brain normally present during REM sleep. And then he's wondering how the bilateral stimulation, whether it's the eyes, tapping, or the sound, activates the systems by forcing the brain to constantly reorient to new locations in space. In this way, EMDR can push start a broken down REM machinery that is required for brain activity to effectively process trauma memories. So it's an interesting idea. We can kind of get an idea of what that might look like. Again, these are some more resources. The bottom one here, EMDR Humanitarian Assistance Program, those are therapists who have done advanced training in EMDR, are proficient in EMDR, and are volunteering their time around the world when there is a crisis. Oklahoma City bombing, the hurricanes that have hit the Gulf, 9/11. I think it was formed after 9/11 because so many therapists wanted to go out and help. And so those are people donating their time to go provide EMDR to individuals in need all around the world. Hopefully I've given those of you with DID kind of where you fit in, where EMDR does or does not fit in, establishing safety, learning resources and skills for self-calming, centering, grounding, learning how to stay present, getting in touch with what's going on inside, learning your system, and trusting your therapist and working through all those layers of conflict and anxiety in developing a relationship with a therapist and the things that happen in therapy that can be quite challenging at times. Trauma happened in relationships. That's what caused your DID. So bringing a therapist into your life is a very scary venture, and I respect and understand that. So first phase of therapy really needs to take its time. It might be many years. And it's not until you have established enough, it's not a perfect state, but it's enough confidence in your own ability to take care of yourself and to get through some of the dips that you would ever consider doing trauma processing. So, and it's not until that trauma processing phase that you and your therapist talk about doing EMDR processing. Hopefully that helps you understand when EMDR is going to happen. It should only be in that final phase of therapy. If there are more questions, send them to Felicity, and maybe we can check back in a week or so on questions that have come up or thoughts that have come up